Hello, everyone. My name is Mary Scott Herring, and I am presenting today on the GO team, which is housed at the R. Adams Cowley Shock Trauma Center. There is nothing like shock trauma anywhere in the world. The R. Adams Cowley Shock Trauma Center has a PARC designation, which means it is a primary adult resource center for trauma, placing it above level 1 trauma centers. Its mission is to save lives and reduce disability of the critically ill and injured persons in the state of Maryland. We are so good at it that the military sends its doctors, nurses, and scrub techs to us to train up before they deploy overseas. This is the kind of thing that we're called for. This call involved a young man in his 20s who was looking at his phone GPS, and he lost control of a crane truck. The truck overturned, and he, as well as 2 other passengers, became trapped under the crane. The 2 other passengers were extricated in about an hour, and they were taken to the closest hospital as priority 2 patients. Our patient was just freed from the vehicle when we arrived on the scene. A couple of highlights from this relatively uneventful transport. The patient was hemodynamically stable. The EMS teams, they did a great job of keeping the patient warm on the scene, and that was in spite of a 2-hour extrication. He didn't require any resuscitative interventions, but he was a very difficult IV stick. And fortunately, 2 Express Care folks were able to get a 20 gauge peripheral IV, but it was our CRNA who performed our first ever GO team ultrasound guided large bore IV insertion. And she got a 16 gauge nonetheless. And then we used the ultrasound en route to perform 2 fast exams on our way back to shock trauma. So our ultrasound, new toy, we like it a lot. The objectives of this lecture are to describe the GO team and to discuss our training and capabilities. I want to take the time out to share what equipment we'll bring to the scene and what supplies we have readily available. We'll examine how the GO team is activated. And just for fun, I want to review the demographics of calls historically that we've responded to, along with a few case studies, which we'll just kind of talk about some case studies as we go along. In the middle of this picture is one of our CRNAs, Bill Howie. He's a longtime trauma CRNA, retired military and first responder. The GO team is generally activated when the incident commander anticipates a prolonged extrication or entrapment scenario that will take longer than an hour, or a patient is very unstable or potentially unstable and unable to transport. And historically, these are cases that we've been called to. It may also be useful to activate the GO team for mass casualty incidents, such as the gas line explosion in Baltimore Reisterstown last year. The GO team is made up of a certified registered nurse anesthetist, CRNA for short, and a physician, usually a surgeon, though it may also be a critical care physician or emergency room physician. Here on the left, we see Dr. Slobosian, who's an orthopedic surgeon, also active military. And in the middle is Crystal Thomas. On the right is Mike Broussard. They are both CRNAs. Mike was a former paramedic before he became a nurse and a CRNA. Obviously, our first responder training isn't as in-depth as all of yours. And, that's not where our skill sets lie. But as I said, many of our team members were prior military or first responders themselves. We do, as a GO team, do training in EMS protocols, hazmat, and incident command. And in the last few years, we've been doing much more simulation. And we love invitations from Maryland EMS and firefighters to join them in simulation exercises. Helps us get to know you, helps you get to know us. This was one of our first multidisciplinary simulations with Anne Arundel Fire Department. There were firefighters, paramedics, state troopers, GO team CRNAs, GO team physicians. And what made it really special was it was one of the hottest days that you could imagine in August. It was 100 degrees in the shade. So imagine how that felt, and you guys live it. So, in all that turnout gear. We had a great time doing entrapment simulations with everyone. And we love to do it because, like I said, it gives us a chance to not only see what the various units have in the field, but we get to meet you in a non-emergent setting. And, you know, it's a great chance for us to see what equipment everyone has, what their capabilities are, and we get to talk to you about what we can bring to the table. There on the right is Cindy Sampson, or on the left rather, is Cindy Sampson. We were doing a trauma simulation in the simulation lab. We were running down our skills list, things that we don't often do, but are critical skills, just like you do. It looks like she was having a very good time. And then to the right is Bill Jansen, MSP, and Estefania Sanchez, CRNA. And we were at Sparrows Point, and we were working on helicopter simulations, because what we realized was that about almost 75% of our deployments are via air.
Hey.
Maryland first responders do an amazing job. Thank you. You get the patients to the trauma centers quickly so they can be well cared for. And you know, what the Go team brings are some extra toys and tools to help make your job easier. We bring advanced video laryngoscopy in the form of a GlideScope Go. We have the ability to place central lines and IV access, which is made easier with our new ultrasound device. And, you know, CRNAs can provide the full spectrum of anesthesia to patients. And that might be enough sedation to get them extricated, or a full-on general anesthesia with an LMA or an endotracheal tube if we need to perform an amputation. And our physician colleagues bring with them the ability to place chest tubes, to surgically control bleeding, to amputate an entramped limb if necessary. And something we're currently working on is the placement of a Roboa in the field. And that's a true life-saving device for someone with devastating internal bleeding. Resuscitative endovascular balloon occlusion of the aorta, or Roboa. It's a minimally invasive technique using a balloon catheter to temporarily occlude large vessels in the body and support hemorrhagic control. And it's inserted through the groin. So, you know, being able to place this in the field would buy us precious time to get to an operating room for definitive management. So something down the road that we're looking to be able to provide. I always like to share this picture. Our turnout gear was 20 years old, like long since expired, and we're very happy to have our new helmets, jackets, pants, and boots. So we always throw in a picture of that when we talk to folks. There's our ultrasound on the left. So not just for central lines, but doing fast exams en route, potentially regional anesthesia. So another possible use that we can use it for down the line. And then on the right is our Go Team bag. It's full of, you know, items to place lines and help us manage the airway. This is our GlideScope Go. It's a nice low profile device. It's perfect to use in patients with suspected C-spine injuries. We realized when we were at a call on top of the Bay Bridge that it's impossible to see the screen in full sunlight, unfortunately. So a drawback to our video laryngoscopy. These are the medications we bring to the field. Many you probably have, but we bring antibiotics in case we need to amputate, medications to optimize intubating or providing sedation or general anesthesia as needed. We also added TXA, or tranexamic acid, as studies have shown that patients bleed less and they require less transfusions than those who do not receive it. So we'll give folks a gram of tranexamic acid when we come on the scene. We bring our own fluid warmer, a little Buddy Light, and 3% saline, as well as a cooler with 2 bags of fresh frozen plasma and 2 packed red blood cells. And I understand they're talking Maryland about some units carrying their own blood products. I know it's being done in Pittsburgh with good results. So we'll see where that goes. Nothing seems to happen super fast. There in the camo hat is CRNA Banjo Batoon. And I want to emphasize that you should consider calling the GO team when you encounter life or limb-threatening injuries, when the extrication times will be more than an hour. And another reason to activate the GO team is if advanced or surgical services are needed that are beyond your scope. And as I mentioned, mass casualty events. You all are probably more familiar with this map than I am, but here are the locations of the 8 police medevac helicopters across the state of Maryland. They're strategically positioned so that a patient can be transported to any one of the 9 trauma centers in 20 minutes or less. The goal for deployment is for the GO team to be out the door in less than 15 minutes, and we actually have run drills on this, and most make it in about 10 minutes from the time they're notified of the call. And to date, we've never denied a request for a GO team call, and we'll respond by air or ground. What happens is the incident commander calls SysCom and requests the GO team, and SysCom then contacts shock trauma. When shock trauma and express care are notified, a group text is sent out to the entire shock trauma team because, as you know, there are a lot of moving parts. The trauma resuscitation unit needs to be aware and ready to receive the patient. And then the OR has a room placed on standby in case they need to bring that patient back, immediately. So it really takes a team to coordinate, as you can imagine. A few years ago, we realized that no one had ever taken a look at our call logs to explore who called us or for what we ended up doing when we were called out. So we didn't know. We'd never looked at it. So we gathered all of the information we could from the calls that we had records for. And, in full disclosure, many records were lost. The GO team's been in existence for, over 25 years. They've changed recording systems a couple of times. We found a couple of calls that were written down on scraps of paper. One was written on a napkin. So what we ended up looking at were calls from 2011 to 2019 that we actually had records for. And what we found was there were a total of 70 calls for the GO team with 23 completed deployments. So, 2/3 of their 3/4 of the time we were canceled. And so what we knew was we're canceled more than we're deployed. And, it's not surprising maybe, but most of the patients, this is the demographics of the patients, most of them were healthy young adult males. And most of the calls were during the cooler months. I would have anticipated summer, but it actually happened during the cooler months. And almost half were work-related. Most of the patients had a negative toxicology screen, which is unusual in the trauma center. Most folks are positive for some substance. 73%, as I alluded to earlier, 73% of patients were deployed, or the deployments of the GO team to bring the patients back to the trauma center were done via air. And that led us to pursue training at Sparrows Point with the MSP so we could be more familiar with the helicopter and helicopter safety. This is an unfortunate car versus tree call, as you can see. First responders were taxed with an exceedingly difficult extrication. They provided pain management with ketamine, and they prepared the patient for transport via Trooper 1 to shock trauma. The GO team, it occasionally eclipses the praise of the on-scene EMS and fire and rescue. When we're in the air and we're coming down and there's a crowd of people, they all have their cell phone cameras up filming the helicopter landing, right? But, this incident, it clearly highlights the action of those on the scene and how critical those were to a favorable patient outcome. The patient did well, never required ICU care, and, had an excellent prognosis because of what the first responders did. I thank you all for your very hard work in keeping Marylanders safe. And if you have any questions, please feel free to contact me at mherring@som.umaryland.edu, or you can Google UMMC CRNAs and find my contact information on that webpage. Please do stay safe. I wish we were in person because we could talk more about cases and answer any questions that you have. So if you have any questions, send me an email. Everyone take care. Thanks so much. Bye-bye.
California Casualty has been endorsed by the MSFA for 10 years for its auto, home, and renter's insurance. It is our honor and privilege to protect those who protect our communities. Happy 10-year anniversary to the members of MSFA. Thank you for all that you do. For more information about our program, please visit www.calcash.com/MSFA. We look forward to seeing you at various local, county, and state events.